Hi guys, welcome back. We shall now be talking about blood transfusion and its complications. And the first thing that we need to understand with respect to this topic is that we need to do a proper blood grouping cross matching to avoid any kind of a mishap happening in any doctor's practice. That is mainly with respect to a mismatched blood transfusion, which can kill any doctor's practice immediately. So when it comes to blood grouping and cross matching, the ABO system is the one that we basically need to study. So they have asked in the exam regarding one that which chromosome will be related to ABO system, and you are aware of the fact that that would be chromosome 9 and it would be 9q. Here I would just like to point regarding a small misprinting which is present in Harrison. He is mentioned as 9p, whereas actually it is 9q. So that small misprint is the one that I basically wanted to bring to your notice. And then the pattern of inheritance is codominant. Then he has asked that which antigen present on the surface of the red blood cell will decide whether it would be blood group A, B, AB or O. The answer is H antigen. H antigen decides blood group A, B, AB or O. Do remember the fact that those of us who are having blood group A, they will be having H antigen. H antigen in fact is composed of a sugar which has been asked in basic sciences, that is fucose. This fucose is attached to a core of glycolipid. And to this there is addition of N-acetyl galactosamine. So do remember the composition of blood group A, that is H antigen hooked up to N-acetyl galactosamine. But if your blood group is B, then it would be H antigen along with galactose. Whereas if your blood group is AB, then it is H antigen with both of these, that is it would be having both galactose as well as N-acetyl galactosamine. And people having blood group O, it would be H antigen minus both of the above. So do remember this very baseline data that I mentioned before you. I'll repeat the data again so that you can remember it. For blood group A, it is N-acetyl galactosamine. For B, it is galactose. If both are present, it is AB. And then for O, it is minus both of them. When it comes to the most common blood group and the least common blood group, the most common one is easy. I think everybody knows, and that is what Park, the PSM book, says, that for India, the most common blood group is O positive. 45% of Indians are O positive. If he says which is the least common blood group in India, the first answer of yours would be given as Bombay blood group. Bombay blood group is the one where even the H antigen on the blood group is missing. So it is written as OH negative. Do not straight away answer AB negative. That's a common answer that I usually get from my students. But remember the fact that first answer to be given in the question is Bombay blood group. And if it is not given in the options, then in those circumstances, the answer would be given as AB negative for the least common blood group. The second antigen which is present on the surface of a red blood cell is the D antigen. And when it comes to D antigen, a person can be D positive, that is RH positive, or can be RH negative. This is a alloantigen and isoimmunization, but this can occur. Like if a person is B negative, or if a lady is B negative, husband is B positive, then the sensitization in her can occur due to feto-maternal leak, and she can develop antibodies against this D antigen. In the exam, they have asked that with respect to D antigen, it is coded with respect to which chromosome. So like I taught you that chromosome 9 is related to ABO. Remember, chromosome 6 is for HLA, we all know that. D antigen is related to chromosome number 1. About 15% of the world population might be negative for D antigen, so they would be classified as RH negative people. And I highlight the statement again, isoimmunization can occur, that is with pregnancy or after blood transfusion. Even if few ml of blood transfusion is done, like in a B negative, B positive blood is given, then antibodies will be formed, and they can contribute to obviously problems in the form of hemolysis subsequently. Another important antigen which is to be remembered by you is Lewis antigen. Lewis antigen is in fact one of the common antigens which is responsible for incompatibility related to pre-transfusion screening. Lewis antigen is a carbohydrate based antigen, and this is ascribed to chromosome number 19. So let's just revise the chromosomes again. For HLA it was chromosome 6, blood group is chromosome 9, that is ABO, which is codominant. Then for RH I said it is chromosome number 1, and for Lewis antigen carbohydrate it is chromosome number 19. If they ask in the exam that what is the most common cause of incompatibility with respect to pre-transfusion screening, then most of the people tend to answer the ABO system as being the villain, which is not the case. The most common cause of incompatibility with respect to pre-transfusion screening should be answered, I repeat again, not as ABO system, but should be answered as the Lewis antigen. The next one to be remembered is Duffy antigen. This acts like a receptor for Plasmodium vivax. So therefore, if a person is positive for Duffy antigen, that means he is susceptible to Plasmodium vivax. On the other hand, if he is negative for Duffy antigen, that would mean the person would be negative or will be resistant to Plasmodium vivax. So I'll repeat the statements once again. Enhanced sensitivity to Plasmodium vivax or increased susceptibility to Plasmodium vivax, that would be a more appropriate term. Increased susceptibility to vivax is seen in Duffy antigen positive people, and Duffy antigen negative, it would be rather resistance to vivax. Most people tend to answer opposite, that is positivity as being responsible for resistance. That is not the case. Positivity means the chances of vivax going inside the RBC will be increased, so susceptibility is enhanced, and negativity implies resistant to vivax. Now, why we are studying all this is primarily because of the fact that when you're going in for blood transfusion, blood grouping and cross matching is of paramount importance, because mismatched blood transfusion obviously should not occur, and a doctor's license can be cancelled. So you need to be very, very particular, because you see they will obviously penalize the blood bank subsequently, but first they will penalize the prescribing doctor. You see, you are not directly responsible for testing of blood, but as you study in forensic medicine, vicarious liability, that if a technician is making a mistake, they will not penalize the technician, or rather they will first penalize the prescribing doctor. So you need to be very, very particular. And if you have donated blood ever in your life, you would have noticed that in India we are donating something like 350 ml of blood. In America it is 450 ml of blood, and the initial part of the blood that flows out into the tubing, that goes and flows into a pre-donation bag. Why do we have this small pre-donation bag is because, about, I would say, 10 to 30 ml of initial blood is allowed to flow out into the bag, and then the blood flows into the main bag. The advantage of that is that if there is a skin contamination, which would obviously occur in most of the cases, the chances of bacterial contamination of the residual amount of blood in the bag would definitely be minimized. Here I would like to make also a passing remark that if blood has been released from the blood bank, it should be transfused within 4 hours. That's very straightforward, because if you keep it for more than 4 hours, then the bacteria can grow at room temperature, and this would be like, you are inducing sepsis in a person by giving him bacteria in the blood unit. That's definitely a medical negligence. I will also talk about bacteria which can grow at 4 degrees Celsius in the refrigerator of the blood bank, and therefore they can coat the bag surface, and when you poke the bag, the bacteria can go inside, like Pseudomonas, and Pseudomonas sepsis can then subsequently occur in the patient. So to minimize Pseudomonas sepsis, you obviously need to have good quality blood banking or quality control in the blood bank. But if you want to reduce Staph aureus or Staph epidermis or Coagulase negative Staphylococcus, then pre-donation bag helps you in reducing the incidence of especially skin particles and bacteria, especially with respect to Staph aureus, Staph epidermis or Coagulase negative Staphylococcus. Also, I have shown here before you what has been asked in a recent exam, that is a filter. This filter will basically stop the transfusion of white blood cells, because white blood cells can cause complications that I'll explain to you, like febrile non-hemolytic transfusion reaction, or it could be associated with graft versus host disease, to stop the white blood cells. So the concept that is being used nowadays is called as leukodepleted blood, which means that if you are receiving blood from me, let me say I'm B positive, you are B positive, you obviously will not be knowing that I am the donor. But if my blood is being transfused into your body, then my white blood cells can cause problems for you. So to prevent these manifestations from happening, we nowadays are using this special filter set, especially in people who are already sensitized. Like if a lady is multiparous, she's already having her immune system charged up. You see, she might be B negative and she had a B positive husband. So, or she received blood transfusion after her delivery. So she's already sensitized. So people who are already sensitized can be having higher chances of transfusion reactions. So nowadays the concept is that of leukodepleted blood. So this filter will prevent the transmission of white blood cells. You would receive my red blood cells, my plasma, my platelets, but white blood cells will not be allowed to come. And the advantage of that would be a bonus advantage, that viruses like cytomegalovirus, they are carried inside the white blood cell. So if the leukodepleted blood is using, the chances of cytomegalovirus infection will also be minimized, because cytomegalovirus is transmitted via the white blood cells per se. So I have highlighted two things that can be asked to you from the image perspective. One is a pre-donation bag, that is with respect to, they'll give you an image where the blood is being donated by the person individually, And second, they have already described this aspect of leuko or asked regarding this aspect of leukodepleted blood. This is mainly to minimize the incidence of side effects. One of the side effects that we will describe and I'll teach you is called as febrile non-hemolytic transfusion reaction. Explanation will follow, and this will also reduce the incidence of graft versus host disease. It can also reduce decrease, or it can help in reducing the incidence of cytomegalovirus infection. So there are three advantages, with primary being febrile non-hemolytic transfusion reaction can be minimized. Then if you donated blood, you would have noticed that this blood is connected in a bag, and the bag will obviously be having some anti-clotting agents present, because otherwise the blood will clot. It will also help the RBCs. This component inside will help in storage of the blood in the blood bank. So we also need to know regarding the contents which are pre-existing in the bag before the blood flows into the bag. So most of the time we will be using solutions like CPD or CPDA or SAGM, and they are mainly for ensuring that blood is able to store, or blood is stored in a blood bank for relatively a substantial amount of duration. Therefore, I would like you to remember the fact that even in the Second World War, that is 1945 approximately, the Americans knew that they can store blood in a blood bank for almost as much as 3 weeks, and the Germans or the Nazis were not aware of this. Though I'm going a little into history, I would just like to tell you the fact that it is not the nuclear weapons that changed the course of the disease, but the Nazis were very advanced as compared to the Allied powers. But still they lost, because Nazis could not preserve blood as Americans could, because of the simple formula ACD, that is acidified citrate dextrose. So Americans could preserve blood for longer duration. That means that they could save more number of soldiers. Casualties were relatively lesser. I mean, wars in earlier times were mainly built one on basis of how much manpower do you have, or how many manpower can you save. So coming back to the main agenda, they've asked regarding the shelf life of blood with various components that we can be having in the bag unit prior to getting the blood from the patient. The components can be in the form of ACD, CPD, CPDA and SAGM, and we need to remember the shelf life. I'll write the full form of these also, but let's just work out the MCQs with respect to shelf life. So for ACD it is 21 days. For CPD, it is 28 days. CPDA, that is the one that is mostly used in our government hospitals. So that would be 35 days. And when it comes to SAGM, that would be 42 days. Now the full form of ACD would be acidified citrate dextrose. Now this acidified citrate dextrose is not used because of the side effect. It used side effects that it used to cause, and obviously a shorter shelf life in the bank. The storage temperature of blood in a blood bank would be at 4 degrees Celsius. So acidified citrate dextrose, as you can understand from the name, dextrose will help in RBC to get its nutrition. Citrate is the anti-clotting agent. Then is CPDA, that is citrate phosphate dextrose, and A stands for adenine. Why adenine? Because it helps in maintaining the stores of ATP. So CPDA is citrate phosphate dextrose adenine, helps in maintenance of the stores of ATP, which are important for again the survival and the integrity of the red blood cells. And then would be SAGM, that would be normal saline. A would stand for adenine, G would stand for glucose, and M would stand for mannitol. Now, why are we using all of these, and what is the importance of knowing all this is because they will not only help in storing the blood for a substantial duration of time, but they will also prevent the blood from clotting. Like, let us take up the role of citrate, which is usually used in CPDA buffer. Like I said, in government hospitals, most of the time CPDA or so nowadays SAGM is also being used. So citrate will basically bind to calcium, and calcium is a coenzyme in the clotting cycle. So it will prevent the clotting of blood, and therefore the problem is that if the technician has put more of citrate, you see the amount of citrate is very specified. I'm just showing you a slide, you don't need to remember this. You see the ACD buffer requirement in the unit of blood is about 15 ml for every 100 ml, and in CPD it is about 14 ml, which is to be put in the bag before the blood is of the patient is obviously, if I am the donor and you taking blood from me, then the bag of blood should be having this already, the CPDA present in it, 14 ml per 100 ml, so that you can obviously mix it in the bag and then preserve the blood unit. Now, the technician who's 10th pass or maybe even 8th pass, because you see nowadays cost considerations and salaries, etc., might be varying for people with different skills. So a lot of time these local blood banks, or I would say any hospital that wants to do cost cutting, they might hire people with less skills, with less education. So this less educated technician might actually put more of the CPDA buffer. Instead of 14, he might put 18 ml, and he might think the doctor sir will not come to know. And obviously you won't know immediately till that blood is given to somebody. So one of the big time risks that I want you to remember is that if citrate is in excess, so I'll write the word citrate toxicity, it can cause mayhem in the body of the patient, and that has been again recently asked. One of the biggest problems with citrate toxicity would be that it will not only result in hypocalcemia and tetany, that's a risk anyway, and tetany, as you are aware, can cause laryngospasm and the person can expire because of it. So if you read about a question where after blood transfusion person is having laryngospasm and difficulty in speaking with Trousseau sign, Chauvet sign coming up, then you have to take into consideration tetany as a possibility. What I'm also worried about is this citrate will be metabolized by the liver to produce bicarbonate. So in these patients, there will be excess production of bicarbonate, which will result in development of metabolic alkalosis. Once this metabolic alkalosis component will develop in a patient, the alkalosis component can also contribute to encephalopathy in a patient. Both acidosis and alkalosis are debilitating in a sense that they damage the integrity of the blood-brain barrier, and therefore encephalopathy manifestations can occur. So two complications that are very frequently asked in the exam are hypocalcemia and metabolic alkalosis. Another complication that I would like to mention, especially with respect to prolonged storage of blood, would be that if the blood is stored for a very long duration, the sodium potassium pumps will fail. And due to failure of the sodium potassium pumps, there would be a possibility that the blood levels of potassium will begin to rise. Another explanation I can provide is that RBCs are loaded with potassium. Now, if they are giving, I would say, blood which is near its expiry date. You see, you asked for fresh blood, and due to corruption issues, they're changing the sticker on the bag, and they're giving near expiry blood to the patient. Then this blood, when it will go in the body of the patient, the spleen will destroy it, and the RBCs that will be destroyed will cause hemolysis. But worse than hemolysis, I'm also worried about the fact that destruction of RBCs will result in hyperkalemia that can cause bradycardia. It can contribute to diastolic arrest of the heart. Potassium values, if they hit upper circuit of 8 milliequivalents per liter, then there is a high possibility of patient expiring due to diastolic arrest of the heart. I said two reasons for hyperkalemia. One of the reasons for hyperkalemia can be that due to prolonged storage, there is failure of the sodium potassium pump that operates normally, because a sodium potassium pump, as you know from basic sciences, requires energy. So failure of sodium potassium pump is one of the reasons on prolonged storage. And second, I said that the blood was almost near expiry due to prolonged storage, obviously. So near expiry blood, when given to a patient, the spleen will destroy these RBCs, and the potassium suddenly will spike in the blood and can contribute to diastolic arrest in a patient. So from the metabolic profile, I would like you to remember these three statements of mine right away. Hypocalcemia, alkalosis, and hyperkalemia are three reasons why we are today talking about complications of blood transfusion. So on the basis of the aspects that I've explained to you, we will just summarize the important complications of blood transfusion, which are usually asked to you in the exam, where usually the question being asked is, what is the most common complication of blood transfusion? Well, it would be written in short form as febrile FNSTR, but I'll write the full form here, so kindly be patient while I write it before you. That is febrile non-hemolytic transfusion reaction. This happens to be the number one complication of blood transfusion, and if that will happen, a relative and a patient both will ask you, doctor, why did this happen? Your answer in the MCQ and to the non-medical patient will be that this is because of antibodies. I mean, even people with little bit of science background can understand what antibodies are. I mean, immunity concept you can explain, and you can explain that no two human beings are alike. So you can say that it is due to antibodies to donor leukocytes. You see, like you and me both are B positive, so we are matching only for two antigens, no, B and positive, but there are so many antigen systems present on the RBC, we are not matching for all of them. So antibodies against donor leukocytes / antibodies against HLA antigens are responsible for febrile non-hemolytic transfusion reaction. Now, who are those people who can be having these antibodies to donor leukocytes? Then a multiparous woman. If she has already given birth to multiple babies. Every time she had a baby, you see her immune system was sensitized, because there's a possibility that she's a Rh negative person and her immune system was sensitized as her husband was Rh positive, the baby is also Rh positive. So immune sensitization of the mother has already occurred. Or after delivery, maybe she had excessive bleeding, so the gynec decided to give her blood transfusion. Every time you receive a blood transfusion, your immune system is stimulated by large number of antigens. So she's having pre-existing antibodies which will attack the donor leukocytes, and these leukocytes damage will cause cytokines release like interleukin 1, and therefore there would be fever developing in a patient. So do remember the fact that multiparous women or people who have received multiple blood transfusions, which could be due to various hematological bone marrow related disorders. So people having received multiple blood transfusions and multiparous women are having increased risk of developing this complication by the name of febrile non-hemolytic transfusion reaction. So once we get this, we need to understand how the patient will present. The initial profile will be that the patient's body temperature will rise by as much as 1 degree Celsius. Now that is pretty substantial, but you don't need to stop blood transfusion in this particular case. You just need to give antipyretics to the patient, and in fact this complication, most of the time you will find that gradually the complication eases off in the patient. Though ideally nowadays they are saying that this complication, because we are talking about patient care, quality care, so they say that ideally this complication should be prevented. So to prevent this complication from occurring, the best concept is to go in for usage of leukodepleted blood, which will mean that we will use a special filter, and that will prevent the white blood cells from going across. You see, in the body of this lady, antibodies are already pre-existing, but they will have to attack white blood cells, then they will release cytokines. If you will deliver her leukodepleted blood, which does not contain white blood cells, then in those circumstances the incidence of this complication will definitely go down. So textbook says that there is no need to stop transfusion. This is not a life-threatening complication. There is no need for investigational workup to be done in this case, because this side effect is of mild nature. Therefore there is no threat to life of the patient, but you have to be very careful, because you should be able to differentiate this complication from, let me say, anaphylactic shock, because anaphylaxis can also initially cause fever, but then the person can deteriorate. So vital monitoring is of paramount importance whenever blood transfusion is being given to the patient. Apart from febrile non-hemolytic transfusion reaction, which is overall the most common complication, sometimes in MCQs they might write the word allergic reactions. Now, how would allergic reaction be different from a febrile non-hemolytic transfusion reaction? Then allergic reaction will usually present mainly in the form of not fever, but mainly presents as urticaria. The patient after blood transfusion within few minutes will start having itching all over the body. For management of this condition, he says that you need to stop transfusion, not permanently, but temporarily. So there is no need to send the unit of blood back to the blood bank for retesting or blood grouping, cross-matching or direct Coombs test to be done. It is just that he says temporarily stop the blood transfusion. Mostly the itching component will spontaneously reduce, and if it is persistent, you can give antihistaminics to the patient. Like we can give injection of diphenhydramine, and this will make the patient feel relatively better, and then you can resume the blood transfusion in the patient. And again, this complication usually tends to pass off. It's like the initial first few minutes, then this complication can occur. Stop the transfusion, give a shot of diphenhydramine intramuscular, and the complication will pass off. But you have to be very, very careful, because some patients can definitely have anaphylaxis. Now, anaphylaxis can happen in career of any doctor, and it is of paramount importance that a doctor should be able to identify this. So what will tell you that it is anaphylactic shock, because anaphylactic shock is related to histamine release. Histamine causes vasodilation. So the blood pressure of the patient will immediately start falling. The heart rate of the patient will start climbing. That is why they say that the vital monitoring should be done every 5 minutes initially for the first 15 minutes. Then you can make it at 15 minutes, then half an hour interval. But vital monitoring is of importance to pick up anaphylactic shock. Anaphylactic shock can also cause development of central cyanosis in the patient. Why? Because the histamine release will contribute to laryngeal edema. Mark my words, not laryngospasm. Laryngeal edema that will contribute to central cyanosis in the patient. The person might start developing stridor. There might be rhonchi in the chest. The reason for rhonchi is again explained by the bronchospasm secondary to histamine in the patient. There would be associated pruritus in the patient. So do take care of these aspects that I'm highlighting, because anaphylaxis has managed on a war footing. You need to immediately stop the transfusion. you will be providing to the patient subcutaneous adrenaline. So emergency tray should always be available. Whenever you are giving blood transfusion to the patient, the dilution of adrenaline will be 1 is to 1000. That is, you will be giving undiluted adrenaline. That is, you just break the ampule. You know, one ampule will be having 1 milligram. You just need to break the ampule and give 0.5 milligram of this undiluted adrenaline to the patient. Remember my words here. In cardiac arrest, we will always be using diluted adrenaline, but in this case, we always have to give undiluted adrenaline to the patient. And the anaphylactic shock then has to be managed on a war footing, because once you develop laryngeal edema, you will never be able to intubate the person. Getting an airway will be very challenging for you. So anaphylaxis can occur with anything and everything that is given parenterally. So blood transfusion is obviously not an exception. The fourth complication related from the immunological perspective is a mismatched blood transfusion, and mismatched blood transfusion is also called as acute hemolytic reaction. Now this is again a serious complication which is occurring in a patient. This is an example of type 2 hypersensitivity reaction. It is related to immunoglobulin M. Usually in the exam, one question of hypersensitivity reaction is usually there. So this is like one example, mismatched blood transfusion example of piece of cake, type 2 hypersensitivity. Now what is going to happen in the patient when acute hemolytic reaction will occur in the patient is that hemodynamic instability will obviously be a profile. That is, the heart rate will start increasing, the BP will start falling in the patient, there will be fever, there will be chills in the patient, the temperature might increase by as much as 1 degree Celsius. There could even be a rash developing in the arm or all over the body of the person. So initially you might be having varied impressions, like this could be febrile non-hemolytic transfusion reaction. Is it a anaphylactic shock occurring in a patient? But how do you differentiate is the fact that in a mismatched blood transfusion, whenever it will occur, it will contribute to patient experiencing chest pain and also flank pain, because the hemolysis that will occur in this patient will affect coronary circulation, so chest pain can be experienced. And because there would be hemoglobin blocking the tubules of the kidney, there is acute tubular necrosis that will develop in this patient, because hemoglobin is a high molecular weight compound. It will block the tubules of the kidney, so urine output of the person will begin to fail, and there would be pain at the area of the loin or flank pain. The patient will start having passage of black color urine. All these manifestations that I mentioned before you are very grave, and a doctor's license can be cancelled. Though I would say like this, that we directly are never responsible for it, but then the lawyer can ask you that, doctor, were you not responsible for quality control? And you would not have an answer. So ideally, I would personally advise you to be always associated with a good quality blood bank, where quality issues like these are not there. Otherwise, it becomes very difficult to handle these problems, and the patient will be having black color urine, hemoglobinuria, kidneys can fail. What will you do in this particular case? You immediately have to stop blood transfusion and do a workup of the patient. There is no special workup required for the previous aspects of complications that I've been discussing, but for acute hemolytic reaction, mismatched blood transfusion, workup is mandatory. What workup will you do? You need to demonstrate the presence of hemolysis. Whenever there is hemolysis in the body, haptoglobin is consumed. It binds to hemoglobin. So because haptoglobin is consumed, the haptoglobin values in the body will become less, and LDH is inside the RBCs. So when RBCs will burst, like B positive patient was given A positive blood, or A positive patient is given B positive blood, then in those circumstances when RBCs will burst, there would be release of lactate dehydrogenase, so LDH values will be increased. The trigger can be substantial to cause even DIC and coagulopathy in a person, so coagulogram should be used or evaluate in the patient. Or repeat blood grouping and cross-matching should be done, because there's a possibility that there was a swapping of the samples of the patient. There could be two patients with same surname or with the same first name present in the hospital, and therefore, I have had instances when colleagues of mine, they did not notice that two patients with the same name were admitted in the same ward, and well, the swapping of blood unit happened, and it was all hell breaking loose with media coming up and things like these. So I would definitely like you to be very particular whenever you are giving blood to the patient. You should do proper matching of the unit of blood. Nowadays we are having better system. We have a barcode that the patient, whenever patient is admitted in the hospital in corporate setup, there's a barcode that the person has to wear all the time in the hospital premises. So we have to do matching. We have these machines by which we can scan the barcode, match it with the barcode of the blood bank. But in government hospital, lots of time these fancy technology based stuff may not be available, and due to wrong labeling, you see, the basic reason for mismatched blood transfusion is again a question. They said, what is the reason for it? Then the answer for this is mainly clerical error. You see, a doctor is not gonna be, I would say, crazy enough to give a wrong blood to a patient willingly. But if patients are having same name, or there is wrong labeling of the bag, or there is wrong labeling of the sample, then there's a possibility that swaps can occur, and that could be a disaster situation for career of any doctor. So you have to stop the transfusion, do this basic workup of the patient, and initiate diuresis. That's to prevent the shutting down of the kidney. So fluids have to be started. Along with diuresis, he says give Lasix, that is furosemide, to the patient. That's a loop diuretic. Along with this, he also says mannitol. Please appreciate that we do not give mannitol in established renal failure, but at the moment you have picked up the patient early, like after blood transfusion, suddenly the BP is fluctuating, he's febrile, he's having chills, he's having chest pain, he's having flank pain. You need to stop transfusion in the patient because furosemide mannitol needs to be given to flush out the kidneys, because otherwise hemoglobin will block the tubules and person might even require a dialysis. So that's, only if you fail to recognize it. But then these are complications which are definitely important for any doctor's career, that you have to be very very particular with respect to at least these basic four immunological complications that I have explained to you. The ones that I'll highlight which are very frequently asked is one, febrile non-hemolytic transfusion reaction, then is anaphylactic shock, and then is mismatched blood transfusion. And because transfusion based questions are asked every time, so do remember all the clinical associations that I have mentioned with this topic, so that you can work out the information relatively better. Coming to the next complication related to blood transfusion, from the immunological perspective, you need to remember the name GVHD, that is graft versus host disease. This is again a hot favorite with respect to our examiners in the following sense, that this can be seen both after blood transfusion, that is the topic that we're studying, and also with respect to allogenic stem cell transplantation. Now, if first degree cousin, brother or sister is donating bone marrow to the person who's having a hematological disorder, then because the persons are sharing common HLA antigens, there can definitely be a reaction which is called as graft versus host disease. The reason for why do you have graft versus host disease is simple, straightforward. Donor T8 leukocytes or lymphocytes. You see, if I am receiving blood from you or you are receiving blood from me, then your T8 cells, they will recognize my antigens as foreign, and therefore if I receive blood from you, my body can be attacked by these leukocytes. So we need to understand what are the target organs of these donor T8 lymphocytes to understand manifestations of graft versus host disease. And I'll say a very interesting fact. You see, if a person has received blood transfusion from a family donor, like elder brother is sick and the younger brother is donating blood, and the younger brother has given blood in the blood bank, and the same unit of blood was given to the elder brother. Like in movies they show that elder brother's blood is being given to younger brother, vice versa. That is all because it is a movie. In reality, if two people are siblings, real brothers and sisters, and you're giving blood of a brother to a sister, sister to a brother, assuming both are having same blood group, right? B positive, B positive. But if you are, because they are sharing common HLA antigens, they can be a development is GVHD. I repeat my statement once again. Because a sibling brother or sister can be sharing HLA antigens, therefore there could be a development of GVHD. That is why we as doctors discourage donations or directed donations from family member. What I mean by directed donation is like a family says that okay, this person in my family is undergoing a surgery and the surgeon has asked for 2 units of blood to be donated. So we want that this person's younger brother and sister's blood should be given to this guy. Then we will say no. You see, if I need blood, my family members will obviously donate blood, but I will not receive their blood only. I will receive somebody else's blood. It's not that I will receive only blood from my brother or sister only. If you do directed family donation, then GVHD manifestations can occur and they can be fairly serious. So we will study now what are the clinical manifestations that can occur, and he can give you a clinical scenario like this where he will say that 2 family members are interrelated and blood of one was given to another, and after 8 to 10 days, not immediately, the patient is having complications. That is, after 8 to 10 days of post blood transfusion scenario, there would be development of fever in a patient. If immediately after giving blood transfusion it is fever, then it's obviously febrile non-hemolytic transfusion reaction. But if he says after 8 to 10 days there is fever, there is diarrhea, there is jaundice, that is maybe obstructive jaundice developing in a patient, which could manifest initially in the form of pruritus. So what are the organs which are affected in graft versus host disease? Skin is involved, GI tract is involved, liver is involved, and because it's a immunologically mediated disorder, so fever will anyway be present. In fact, in these patients, there's a possibility that there can be a frank pancytopenia developing in a patient where like RBC, WBC platelet count will fall, and there is even a possibility of death in graft versus host disease after 3 weeks. So this complication is relatively a delayed complication that is occurring in a patient. And what is the best way to prevent it? Well, don't allow these T8 lymphocytes to come into the body of the recipient. And how can you prevent these donor lymphocytes from coming? There are two methods. One method is to use those filters that I was talking to you earlier. They will prevent these lymphocytes from being transmitted, and therefore the chances of complications will be lesser. But currently they have shown that a much more superior method as compared to using a filter, because filters can get blocked, they're expensive obviously, so we can use irradiated blood. Now this again from Indian perspective would be a little challenging, but this is what Harrison says. He says that if you are giving irradiated blood to the patient, then the chances of this complication will be minimized. Why that is so, that will become more obvious from my next statement. If they ask you that what is the most radiosensitive blood cell, I think all of you can remember pathology class. Most radiosensitive blood cell is lymphocyte, and lymphocytes are the one which are responsible for development of graft versus host disease. So if you kill them, then GVHT will not occur. I repeat my statement: most radiosensitive blood cell is lymphocyte. A related MCQ: most radio-resistant blood cell is platelets. You are aware of both of these statements from your basic sciences classes. What I am using here is, because I know the fact that lymphocytes are radiosensitive, I will ensure that the unit of blood in the blood bank, when it is stored, it is given radiation that will kill the lymphocyte. And now when you will give this unit of blood to the patient, then the chances of GVHT will not occur or will be minimized. Another way to prevent this from happening is obviously a filter, but I have not written that because the filter is more suitable for preventing a development of febrile non-hemolytic transfusion reaction occurring in a patient. The most common complication that I've explained to you is febrile non-hemolytic transfusion reaction. And apart from this, I have described these 5, I would say, immunologically mediated reactions that could be occurring in a patient. Now, in some questions, he might rather ask you regarding what is the most common cause of death occurring after a blood transfusion. Then the answer should be given as transfusion-related acute lung injury. I repeat my statement again. Overall, the leading cause of death after blood transfusion, though this is a rare event, is TRALI, that is transfusion related acute lung injury. I would here also like to mention the fact that the incidence of TRALI is common in the first 6 hours of transfusion, and the incidence is more mentioned with fresh frozen plasma as compared to that of whole blood. I know some sources on the internet would be telling you that it is more common with whole blood, but that is what not CMDT says. CMDT says that incidence of TRALI with fresh frozen plasma is more as compared to whole blood. So we next need to understand why would you be having TRALI. For this, I would like to say that TRALI will mostly be seen in your hospital if you have taken blood donation from a multiparous woman. Now, please appreciate, earlier I was telling you that if a multiparous woman will receive blood transfusion, she can have allergic reaction and she can have febrile non-hemolytic transfusion reaction. Here I am saying the multiparous woman whose immune system is already charged up, she is the donor. Or a person who has already received multiple transfusion, like he's a war veteran, he's a Kargil war veteran, he had received multiple transfusions, he sustained a grenade blast injury. So if a person has received multiple transfusions already, then his immune system is already charged up. This time the donor is either a multiparous woman or the donor is a person who's already received multiple transfusions. So in the body of this person there is pre-existing antibodies. These antibodies are active against, or I would say these antibodies are antibodies against HLA2. So it is anti-HLA class 2 antibody. Because the immune system is charged up, they are also having antibodies by the name of antibodies against HLA class 1 antibody. And they are also having antibodies against neutrophils, which is called as anti-neutrophil antibody. Get the data right, guys. This is important for you from the exam perspective. I'm saying this time the reason for TRALI is antibodies which are being transfused. When I was talking about graft versus host disease, I was directly blaming donor T8 lymphocyte. But this time I'm blaming the antibodies which are already present in the body of the patient. When these antibodies will now come in the body of the recipient, let us now see how the recipient's body will respond to these antibodies. These antibodies are against nucleated cells, they are against HLA class 1, class 2. So what these antibodies cause is, they cause the white blood cells of the recipient to aggregate in the lungs. Look at the surprising statement I'm saying. The antibody which is present in the blood of a multiparous donor woman. So how to prevent TRALI? Don't take blood transfusion from a multiparous woman ideally. Do not take donations from a multiparous woman. Do not take donations from people who have already had multiple transfusions already. Like this Kargil War veteran wants to donate blood. He's already received blood transfusion. I will say, no, so sorry, sir, I don't want to take a blood from you in my blood bank, because when I will give your blood to somebody, the antibodies of your immune system will be transmitted into the body of the recipient, and it will cause damage to lung parenchyma of the recipient. So leukocyte aggregation will occur in the pulmonary capillaries of the patient, which will result in ventilation perfusion imbalance that will explain the respiratory distress that is developing in a patient. I repeat my statements again. If he talks about graft versus host disease, he is blaming donor T8 lymphocytes. Here we are not blaming any cells, we are blaming antibodies which would be transmitted from the body of this donor to the recipient, and therefore there would be a ventilation perfusion imbalance causing an acute respiratory distress syndrome or ARDS kind of a manifestation. Another problem would be that the antibodies will be causing a release of cytokines from the leukocytes. Like the leukocytes of the recipient are this time being affected, so release of cytokines will increase the capillary permeability. The capillaries that I'm talking about here is that of the lung parenchyma. If you enhance the permeability of the capillaries, then the fluid will accumulate in the alveoli. You see, normally in the alveoli there is no fluid present because our endothelial cells which are surrounding the alveoli, they are not allowing the transportation of fluid across the tight junctions and the gap junctions. What I'm saying here is that let us assume this is the alveoli of the patient. I'm just using a capital A, and these are the pulmonary capillaries which are surrounding the alveoli, which is the basic unit of gas exchange. Now every blood vessel will be having endothelial cells which are going to line and form the integrity of the blood vessel. In patients who are having a transfusion related acute lung injury or ARDS, what happens is that there is movement of fluid from the blood vessels into the alveoli, which will result in development of pulmonary edema. You see, if I was saying person is having heart failure, then I would have taught you in heart failure the pressure inside the blood vessel is more, so there is transudation of fluid. So in cardiogenic pulmonary edema, because the pressure in these blood vessels is higher, the fluid will leak from these blood vessels into alveoli. But in this case, I never spoke anything about that there is any increase of hydrostatic pressure. I said the cells have been damaged with cytokines. So the fluid can leak between endothelial cells, and therefore the pulmonary edema that will develop in the patient is called as non-cardiogenic pulmonary edema. I will highlight this statement again. If you are having congestive heart failure, in congestive heart failure what happens is the congestion is the English word. So congestion will cause fluid to leak from these blood vessels into the lung parenchyma, into the alveoli. So the transudative pulmonary edema that occurs in a patient is due to increase of hydrostatic pressure in heart failure. That is called as cardiogenic pulmonary edema. But in non-cardiogenic pulmonary edema, there is cytokines damaging the integrity of the endothelial cells. It is the lining of the endothelial cells that is damaged, and therefore there is a non-cardiogenic pulmonary edema developing in a patient. For confirmation of diagnosis of TRALI, one, we need to demonstrate that the PaO2 FiO2 ratio. PaO2 is partial pressure of oxygen, FiO2 is fraction of inspired oxygen. This should be less than 300. The second feature that should be demonstrated is that there is a evidence of absence of left atrial hypertension. Please appreciate the fact that whenever there is cardiogenic pulmonary edema, then the pressure of the left atria will rise, so we will call it left atrial hypertension. Here he is saying evidence of left atrial hypertension. I would like to tell you the fact that one of the reasons why I have updated this lecture is because till last year I taught your senior batch that PCWP less than 18. is one of the criteria for diagnosis of ARDS. But now in the current Harrison, he has removed the word PCWP less than 18 and he's mentioning the word evidence of absence of left atrial hypertension. What that basically means is that there is no congestive heart failure, because in congestive heart failure, if the left ventricle will fail, the left atrial pressure will rise and that will cause back pressure changes in the lungs. So for diagnosis of TRALI or ARDS, the PO2 FI2 ratio should be less than 300. There should be absence of left atrial hypertension. When insult will occur in the lung, insult could be due to swine flu or due to cytokines released after blood transfusion, then the insult should cause manifestations within 7 days. Here, obviously, in TRALI, I was teaching you that symptoms will develop as early as 6 hours. But generally speaking, when we talk about ARDS as a broad term, then the patient should be having within insult 7 days, there should be development of symptoms, and the chest X-ray will be totally hazy white. That bilaterally hazy white will be called as bilateral infiltrates that would be present in the lung parenchyma of the patient. So for diagnosis of TRALI in a patient, we need to be having these diagnostic criteria. Remember that in transfusion-related acute lung injury, the blood pressure of the patient may remain normal or even relatively lesser. Jugular venous pressure of the patient will be normal. JVP is normal in the patient because this is non-cardiogenic pulmonary edema. Therefore, if you will check the values of BNP, B-type natriuretic peptide, the values of BNP will also remain normal in the patient. So features of TRALI to be demonstrated are that hemodynamically speaking, blood pressure should not be elevated, JVP should not be elevated, BNP should not be elevated, because if these values tend to go on the higher side, then it is not TRALI. Then it is rather a counterpart aspect that you need to remember, which would be the next complication that I'll mention before you. That is the seventh complication, that would be called as TACO. TACO would stand for transfusion associated circulatory overload. Transfusion associated circulatory overload will be having increase of blood pressure. Volume overloading will cause increase of blood pressure, increase of JVP, and increase of BNP in a patient. So if you look at the vitals, if you look at the BNP levels, you can definitely make a difference in the question. Just to explain transfusion associated circulatory overload, I can rattle off a question here before you that has been asked in the exam. He described a CKD patient. He said that he is scheduled for dialysis next week. He is a known case of CKD. You have been doing dialysis in this patient every alternative day, that is 3 times per week, and over the weekend you found his hemoglobin is very low. So there's a scheduled dialysis of this patient, and the hemoglobin of this patient at the moment was given to be 7 gram%. So the doctor has decided to give 2 units of whole blood to this patient. Ideally, 1 unit of blood should be completed over 4 hours. Here the question very innocuously mentioned that 2 units of whole blood were transfused into this individual in a span of approximately 4 hours. I repeat my statement once again. Normally 1 unit should be given within 4 hours. Here 2 units have been given over 4 hours because the doctor was trying to be quick in trying to raise the hemoglobin values so that we can plan a hemodialysis for the patient. And the patient now had development of respiratory distress. The blood pressure of the patient was found to be relatively elevated. The chest of the patient was having bilateral fine crepitations. Now mark my words there, bilateral fine crepitations can be found in any case of pulmonary edema, both in non-cardiogenic pulmonary edema or TRALI there would be fine crepitations, and even there would be crepitations present in a patient of transfusion associated circulatory overload, but the vitals will definitely do the trick for you. I repeat my statement once again. Bilateral fine crepitations is a auscultatory finding that is found in all patients of pulmonary edema, whether cardiogenic or non-cardiogenic really does not matter. So you cannot differentiate on the basis of bilateral fine crepes which are secondary to the fluid accumulation in the alveoli of the patient. Rather, you will have to look at the hemodynamic parameters for the patient. Based on whatever I've said, before we go to the 8th complication, I would like to here mention that if you are attempting a MCQ in the exam and a person after blood transfusion has started experiencing breathlessness, respiratory distress, what is the thought process of yours that is to be considered? One complication that you have to evaluate is possibility of TRALI. Second is TACO, that is transfusion associated circulatory overload. Another possibility we kept in mind is tetany in a person, because there would be laryngospasm and tetany that could also manifest as breathlessness in a patient. Now, how would you pick up TRALI? The patient will definitely mention bilateral fine crepitations. The same thing can be present for taco, bilateral fine crepitations, that is circulatory overload will cause bilateral fine crepitations. But the blood pressure values in trolley will be normal to low. The jugular venous pressure will be normal in the patient, and the blood test we can do is BNP levels. BNP will be normal, B type natriuretic peptide. If in the question you find that the blood pressure values are elevated, JVP values are elevated, Kussmaul sign is described, and more importantly, BNP levels are elevated, it is circulatory overload or TACU. You see the difference is in trolley you will have to put the person on ventilator, go for low volume ventilation. For TACU you will have to give diuretics to the patient to ease off the circulatory failure. Then tetany can also contribute to breathlessness in a patient, which is secondary to the laryngospasm, so oxygen saturation can fall. In any patient who is having tetany, which is because of citrate toxicity, remember in the earlier part of the discussion, I explained to you that if a technician has put more than the specified amount of the anticoagulant in the unit of blood, then citrate toxicity can cause laryngospasm, stridor, breathlessness, cyanosis can be described in the patient. Tachycardia could be described in a patient, but then there would be no mention of any BNP levels in a patient, or they will be normal in the patient, and there is chest is bilaterally clear. In the chest of the patient, you will be having conducted sounds. Those conducted sounds could be due to laryngospasm, but there will be no fine crepitations in the chest in patients who are having tetany. So these are three important causes that you need to remember, especially with respect to respiratory distress after a blood transfusion. A patient received a blood transfusion and then he is having a development of fever. So what should be your thought process? It could be febrile non-hemolytic transfusion reaction, but it could be something as serious as anaphylactic shock in a patient, or it could be something as serious as mismatched blood transfusion in a patient. So whenever a question is describing this kind of a scenario of development of fever, chills, you have to keep these in decreasing order of importance. Obviously, the first one will pass off by itself, then the second complications can occur, but then this is the thought process of yours in most of the clinically oriented questions that are coming nowadays. Blood transfusion followed by distress and blood transfusion followed by fever, then these are the diseases which are to be considered in a logical sequence. Coming to the eighth complication related to blood transfusion, we will talk about dyselectrolytemia or electrolyte imbalance that can be seen in the patient. Though I've emphasized this earlier, why I'm repeating this once again is because I just want to sensitize you to the fact that if a person has received, let me say, 2 or 3 units of blood in the recent 24 hours, then there's a possibility that he will end up with metabolic alkalosis, not metabolic acidosis. You see the dangerous triad that we see with multiple transfusion protocol or with trauma-induced coagulopathy is hypothermia. You see, if a person is having trauma, when he will lose blood from the body, then loss of blood will cause shock and shock will cause metabolic acidosis. So a person who's having trauma-induced coagulopathy, we usually have metabolic acidosis because that is the scenario where you give massive transfusion protocol where you might be giving like 6 units of PET basis, 6 units of fresh frozen plasma and 6 units of platelets. That's a separate discussion that I've taken in the emergency medicine section, but I want you to remember the fact that this electrolytemia can contribute to metabolic alkalosis secondary to the excess of citrate which is present in the unit of blood. The near expiry date blood can contribute to shutting down of the sodium potassium pumps resulting in a dangerous hyperkalemia, and the citrate toxicity can also explain the tetany manifestations in a patient. Normal calcium is 9 to 11 milligram percent, and if the calcium values become less than 7, then tetany manifestations can occur in a patient. Coming to the ninth complication, which is worth remembering, is iron toxicity, because if a person is having requirement of recurrent transfusions, like a thalassemia patient is having recurrent factor RBC transfusion, then iron toxicity will occur in a patient, or there could be a development of secondary hemochromatosis. In iron toxicity, that is secondary hemochromatosis, the serum ferritin values of the patient will be skyrocketing. Serum ferritin, you know, is a acute phase reactant, but in this case it is increasing because 1 unit of blood will provide something in the range of 200 to 250 milligrams of iron for the patient. Usually features of secondary hemochromatosis will develop when person has received at least equal to or more than 100 units of blood. Post 100 units of blood, the load of iron in the body will be reaching up to a huge 20 grams. Due to this excessive amount of iron in the body, this is what Harrison says. He says, For hemochromatosis manifestations to occur, usually you need 100 units of blood. So this guy is, let me say, thalassemic, or he child who's thalassemic, and he has been receiving packed RBC transfusions for 3 years, 4 years, 5 years. Children with thalassemia major are transfusion dependent, so you might have to give transfusions in these patients very fast. Why very fast? Because their own bone marrow is not producing normal RBCs, and whatever you will produce from outside, because they're having splenomegaly, the spleen will destroy those RBCs. So you might have to give transfusion every month to these patients. So after a few years, a person might be having secondary hemochromatosis. Due to the secondary hemochromatosis manifestation occurring in a patient, there would be bronze diabetes manifestation. Bronze diabetes manifestation would mean that this iron will be deposited in the skin, so it will cause hyperpigmentation of the skin. The iron will destroy the hepatocytes, so cirrhosis of liver, and it will damage the pancreatic cells also, so there will be type 1 diabetes mellitus developing in a patient. This complication that I'm describing before you is called as bronze diabetes. We will, however, prevent these manifestations from occurring in a patient by using iron chelators. The iron chelators that you can use in the patient is one injectable, that is desferrioxamine, or we can be using deferriprone. Deferriprone is a oral iron chelator. It's a little expensive, can have nasty side effects also, but then we have desferrioxamine, which is given in the form of subcutaneous infusion, and deferriprone, which would be given as an oral iron chelator for secondary hemochromatosis. This is a complication that would mostly be seen in patients who are having rather recurrent transfusion. Then the next part that can be of concern from exam perspective and life-threatening is infections after blood transfusion. Here I'm not talking about HIV and hepatitis B. That has been ruled out by proper testing. You're aware that government of India says that blood should be tested ideally for minimum 5 antigens, that is HIV, hepatitis B, hepatitis C, syphilis and malaria. But here I'm not talking about those common infections like malaria. I am rather talking about bacteria that can grow at 4 degrees Celsius and higher temperatures. One of the commonest infection that is seen after blood transfusion is possibility of sepsis. Then comes hepatitis B. I repeat my statement. The incidence of septic complications after blood transfusion are higher than that of hepatitis B. Though I have said this in multiple sections, I'm repeating once again, the leading cause of transfusion associated hepatitis is hepatitis B. No doubt about it. But if he says which infectious complication is the number one infectious complication after blood transfusion, then bacteria can definitely grow. And the bacteria that I'm talking about here are nasty ones like Pseudomonas. Another one to be remembered by you is Acinetobacter. Then obviously gram-negative coliforms. Transfusion of this is fraught with risk because you will be causing development of frank sepsis in the patient. Another one you can remember for MCQ sake is Serratia macerans. Here I would also like to mention the fact that fresh frozen plasma does not transmit bacteria because fresh frozen plasma is devoid of cellular components. Therefore, the advantage of fresh frozen plasma is that since it is not having any cellular components, the chances of infection will be significantly minimized. So when it comes to bacterial infection chances with fresh frozen plasma, the chances are significantly reduced. On the other hand, platelets are stored at room temperature, and most of the time they have demonstrated that when it comes to bag of platelets, it might be having bacteria from the skin, that is especially coagulase negative staphylococcus. So therefore cons could be growing in the platelet bag. Platelet bag ideally should be given as early as possible, ideally within half an hour of arrival from the blood bank. But cons, that is coagulase negative staphylococcus, is a risk that can occur. So these are again two isolated statements that I want you to remember. The sequence is like this, that incidence of sepsis is given to be higher as compared to that of hepatitis B, much more than that of hepatitis C. So never answer hepatitis C. Transfusion associated hepatitis is hepatitis Bombay, hepatitis B virus B. Incidence of sepsis is higher than that of transfusion associated hepatitis. That is one message. Message number 2, FFP is usually acellular, so it is not going to transmit infection, and platelets, because they are going to be stored at room temperature, the chances of bacterial contamination will be highest with respect to platelets primarily. So infections can be prevented by good quality control with respect to these infections. Also make a note of some viruses which are transmissible by blood transfusion like HTLV1. Then he says hepatitis E may be transmitted, but for hepatitis A he has written rare. So that is again a very controversial question that was asked, that which is usually not transmitted. He said the word not transmitted. So for MCQ not transmitted, the answer should be given as hepatitis A. When you have to compare between A and E, then you have to answer A is not transmitted by blood transfusion. HTLV1 is one of less common infections. HTLV1 is related to development of one tropical spastic paraparesis. That's a standard MCQ that you guys would have done multiple times, and I've just made you remember that once again. Tropical spastic paraplegia, paraparesis. Second complication related to HTLV1 is development of adult onset T cell leukemia. Both of these are straightforward one-liner questions that you should be aware of apart from the clinical aspects that I mentioned before you. I repeat my statements again. The incidence of bacteria is much more than that of viruses. That's the first message. When it comes to viruses, B Bombay is more common than C Calcutta. Hepatitis B incidence transmission is more than hepatitis C. Fresh frozen plasma does not transmit because it is devoid of cellular component. Platelets can transmit it because there is a higher storage temperature. And then I have mentioned few other viruses which can definitely be transmitted. So these are some important complications that are to be remembered by you with respect to possibility of blood transfusion. Other are relatively minor ones like hypotension can occur. Now, hypotension can usually occur especially in patients who are taking ACE inhibitors. Why? Because ACE inhibitors will contribute to higher values of bradykinin. And blood units could also be having higher units of bradykinin. Two more complications related to blood transfusion that I would just like to say as a matter of fact and not jotting them down is that they could be hypotension, especially in patients taking ACE inhibitors. You will notice that hypotension after blood transfusion is common. Why that is so is because stored blood could be containing bradykinin, and ACE inhibitors inhibit the breakdown of bradykinin. You are all aware, dry cough is related to ACE inhibitors again due to overexpression of bradykinin, and it is also a potent vasodilator. It can contribute to hypotension. So I repeat my statement again, stored blood is having bradykinin. If you inhibit the breakdown of this bradykinin, patient has taken ACE inhibitor already. So when you give this blood to the patient containing bradykinin, this bradykinin will not be broken down because ACE inhibitor is present in the blood of this hypertensive patient. So therefore the bradykinin will contribute to vasodilation and hypotension. That's one side effect that you generally should know, because if a person, I repeat once again, is on ACE inhibitors and has received blood transfusion, then he can have hypotension. Second is immunomodulation. You see, blood transfusion results in decrease in immunity. Because of that, there could be a false positive Mantoux. So when you study causes of false positive Mantoux, then blood transfusion is one of the causes to be remembered. Another clinical importance here is that you would have noticed that people who are having recurrent blood transfusions, because immunity is lesser, so the chances of rejecting a kidney transplantation would be lesser. So I would like to put it like this: people who are planned for kidney transplantation, we usually tend to give them multiple transfusions before doing a transplantation. Why? Because that will decrease the immunity, so chances of rejection will reduce. So these are two additional aspects which are given in the book, that is hypotension and improved survival of the kidney transplant graft. It's just as a matter of fact that I've discussed these with you because they don't have significant MCQ importance, so I am not putting too much of importance to these, but then these are the side effects that you have to be remembering for the topic of blood transfusion. So these are the aspects that I would like you to remember with respect to the complications that can be seen with respect to blood transfusion. Thank you so much for listening.